Al. Oh, you can't do, you have to do another meeting?
Sorry to interrupt yours.
I want to move to the regular agenda item, Madam Clerk.
Item 17 is from Public Health Services to receive an update presentation from staff on COVID-19 novel coronavirus.
My understanding is, Dr. Kelaita, you're going to lead this discussion. Okay, thank you. Please proceed.
Good morning. I'm Dr. Dean Kelaita. I'm the local health officer for Calaveras County, and we're here today representing the Public Health Services division of the Health and Human Services Agency of Calaveras County. There's myself, and there's Chris Edgerly, who's the manager of the Emergency Preparedness Program activities of the County Health Department. We wanted to give the board and the public an update on the novel coronavirus situation that's not primarily focused on national statistics or even California data, but's focused on Calaveras County, where we stand with this and what the potential impacts are to the medical care system and the health of our community and our constituents. So I'll just start with a little bit of background and remind you that this is a rapidly developing situation. Numbers that I might give you now might have been updated since I last looked at them last night, and the situation is rapidly changing. So I just wanted to preface the talk by saying that. What is COVID-19? Now, this is a novel coronavirus. Coronaviruses are a family of viruses that cause health problems in people. Respiratory illnesses, common wintertime colds, that kind of thing. So coronaviruses as a family aren't new. What is new is this strain of novel coronavirus that we're hearing about is new. And so there's no immunity in the population to it at all because no one's ever been exposed to it. And it's causing more severe disease than most coronaviruses typically do. The clinical presentation of COVID-19 related novel coronavirus infection is typically mild illness. So 80% of people who get this infection develop relatively minor symptoms: cough, fever, sore throat, respiratory symptoms. They get better on their own without possibly even needing medical attention, and their symptoms resolve. 20% of people, however, may develop more serious disease. 15 to 20% of people, we estimate. More serious disease includes more difficult breathing problems, pneumonia, requiring hospitalization, respiratory collapse, sepsis, and death. So that group of patients can develop, of course, the more serious manifestations of COVID-19 infection, and those tend to be people who are at higher risk. Higher risk individuals are people who are older or people who have underlying health problems, heart disease, diabetes mellitus, other kinds of comorbid health conditions that put them at increased risk. Those are the people that are having more trouble if they are developing COVID-19 infection. The illness is mainly spread or transmitted by droplet contact from one sick person to another well person. So that's how the disease is transmitted, by person-to-person contact from a sick person to a non-sick person. It can potentially be transmitted through contact with surfaces, doorknobs, toys, that kind of thing. But the virus, we don't think, based on other coronaviruses, lives for prolonged periods in the environment outside of a human host, and routine disinfectants that kill other viruses can sterilize or can decontaminate surfaces in the environment relatively easily. The virus can be spread by touching one's mouth or nose after contact with a sick person as well. So what's the situation in the United States? Imported cases of COVID-19 infection from travelers were first identified in the United States. These were people who had been to areas of the world where COVID-19 infection was more endemic, like China, Iran, Italy, South Korea, these other countries where the virus either originated from in China or spread to other countries. And now we're seeing in the United States domestic person-to-person transmission that's happening in our communities. And that's the more concerning problem that we're seeing now as this outbreak continues to evolve. You can see states there on the map that have reported COVID-19 cases. California and Washington are darker color, right? And on the legend, you can see that's because they have greater than 100 to 200 cases. And so California's in that club. Yes.
Is that, in the California numbers, they took people in at Travis Air Force Base and they're taking cruise ship in yesterday. Are these numbers reflected to that?
Yes,
Is that counting those numbers?
Yes, Supervisor Tofinelli, and I'll address that answer with this infographic that's up on the screen right now. So in California, there's been 88 positive cases of COVID-19 infection, and we'd have to update the deaths this morning to 2, as there was another death from a resident of Santa Clara County that was reported last night. And so you can see of those 88 positive cases, Supervisor, 64 of those cases were not related to people who were repatriated to the United States from other countries in quarantine. That was 24 of the 88 cases. So those 64 cases are cases that developed here in the state of California. Of those 64 cases, 31 were travel related, 19 were person-to-person transmission, 10 community transmission. Now, community transmission is a case of COVID-19 infection that develops in a person with no travel history, with no exposure to a known COVID-19 case. This is a silent transmission that occurred in the community, and the concern for that is that there may be other disease transmission that's occurring under our noses in communities that we don't know about because they don't fit the pattern of that travel history from countries that have endemic COVID-19 disease occurring at a high level. There's 10,250 persons who are self-monitoring after having returned to the United States and been screened through San Francisco International Airport and LAX, who are symptomatic, and those people are on self-quarantine. There's 15 labs in the state of California now, all still within the public health system, that have the capacity to do COVID-19 testing now. So not all tests for COVID-19 patients need to go to the Centers for Disease Control and Prevention Laboratory in Atlanta, Georgia anymore. We're starting to get that testing capability out to state public health labs, and we have 15 labs in California right now that have the test kits and capabilities to do the testing. It still has to go through the public health laboratory system, however, and I'll talk about that in a minute. 49 counties in California have individuals who are on self-monitoring protocols, including Calaveras County. So what's the situation in Calaveras County? In Calaveras County, we've got no confirmed cases of COVID-19 so far to date of any resident of Calaveras County. I think that's an important point. We do have some individuals who are Calaveras County residents who were on the Grand Princess cruise ship, and they returned to their homes in Calaveras County, and they were on quarantine for 14 days, home monitoring protocol for the development of symptoms of illness for 14 days. The 14 days went away. Those people were taken off of home quarantine because if you don't get it in 14 days after you've been exposed to it, you're not going to get it, and you're okay. We had a few individuals who developed symptoms during that time, however, and those people were tested for COVID-19 infection and tested negative. So again, we've had no cases in Calaveras County residents. We've had a few individuals who were exposed to a COVID-19 case outside of our community in the capacity of healthcare work. And those individuals have also been tested, and they're on self-monitoring, self-quarantine at home, and the results of those tests are pending. We should have those as early as today or tomorrow.
If I may ask one question, Dr.
Yes.
Kelaita.
Yes, Supervisor.
The tests, I mean, there's been some things going around. Sometimes there may be a false positive. Is there any instances of false negatives where it is actually a positive, or are they pretty standard and overall?
The test is very accurate
Okay.
for COVID-19 infection. If a person does test positive in one of the state laboratories, like I said previously, that there are 15 labs in California now that can perform the COVID-19 testing, any positive results from those individuals will get sent to the CDC lab in Atlanta, Georgia for confirmatory testing, just to be sure. So we'll call a person who tests positive here in California presumptively positive, and then that test will be confirmed just to be absolutely sure. But it's turning out that presumptive positive cases, for all intents and purposes, are real positive cases, and we treat them as such because the test is very accurate. Its level
Very
of
good.
sensitivity and specificity are both very high.
Good, thank you.
All right, so who gets tested? So there is criteria for people to be tested for COVID-19 infection. The criteria for testing are that a person is sick, they have a fever, they have respiratory symptoms, and they've had a travel history to a part of the world where COVID-19 illness is happening in high amounts. They've had an exposure to a COVID-19 case that we know about, or this is kind of a broadened criteria now for COVID-19 testing. A person who is sick, meaning that they have a fever and respiratory symptoms, they are hospitalized, they have had other testing that doesn't show any other explanation as to why they're sick, then we'll go ahead and recommend testing on those people too. So that's broadened now to some degree. But again, the testing still takes place through the public health laboratory system. So if local medical providers in the community have a patient that they're concerned about, they need to consult with us in public health, and then we'll go ahead and okay the testing. We'll coordinate it with the CDC and the California Department of Public Health laboratories that do the testing. In Calaveras County, we don't have our own public health laboratory. We contract with San Joaquin County for public health laboratory services. So San Joaquin County is our go-to public health laboratory when it comes to COVID-19 testing. And we coordinate obtaining the specimens, transporting the specimens to the San Joaquin Public Health Lab in Stockton. And if they don't have the capacity to do the test, which I don't think as of right now, they're one of the 15 labs, they forward the specimen to the appropriate public health laboratory, either Sacramento County or the State Public Health Laboratory in Richmond, California, to complete the testing. So those are the people that we want to test. If a person is a member of the public and they were to have a sore throat and they were just worried that they might have COVID-19 testing, they went to their doctor, it may be difficult to obtain testing on individuals without meeting that more strict criteria at this point because of the limited testing capabilities that we still have in the public health laboratory system. There's discussion of continuing to ramp up testing and to broaden the testing criteria to include people who just are concerned and might want a test. But right now we want to limit the testing on individuals that we suspect have a high risk of COVID-19 infection because they meet that current testing criteria. Wanted to touch on what some of the potential impacts to the medical care system are that we could be looking at. So what this slide shows is that what's called case fatality rate of COVID-19 infection, we're estimating anywhere from 1% to 2% so far, right? That doesn't sound very high. You might think, well, shoot, if 99 people out of 100 get COVID-19 infection, only one dies. That doesn't sound too bad. That's a big deal. because if that level of severity continues, then that could really challenge the medical care system to take care of those people, because that's considered a very high case mortality rate, case fatality rate. In 1968, there was an outbreak of influenza, which had a case fatality rate of 0.1%. And throughout the United States, 38 million people needed medical care, 1 million hospitalizations resulted, and 200,000 people in the United States needed ICU care. There's 46,000 ICU beds in the United States. In the 1918 influenza pandemic, 38 million people also needed medical care. 9.6 million hospitalizations resulted, and 2.9 million people required intensive care. In Calaveras County, Mark Twain Medical Center has 25 beds and eight, I'll say, ICU beds. Technically, they're only running at 6 right now, but they're licensed for 8 ICU beds. So depending on the level of severity of disease, the medical care system in our community could be challenged. And that's some of the assumptions that we're operating under as part of our preparedness activities. So I calculated some numbers. Under a moderate impact or level of severity of the COVID-19 infection, Calaveras County could be looking at a need for 263 hospitalizations and 52 ICU patients. And again, I wanted to lay out for you what our current capacity is, and you can see how that strains and challenges our limited care capacity in our community. And those are some of the assumptions that we need to be operating under. So what are the current local risks? The immediate risk to Calaveras public is considered low at this time because we don't have disease activity occurring in our community. We're still in a containment mode in Calaveras County. Healthcare workers are at increased risk of exposure, and so we're working with the hospitals and the local medical community on what's called personal protective equipment procedures that they wear when caring for sick patients or potential COVID-19 patients. People who have close contacts with, obviously, a COVID-19 patient is at elevated risk. Travelers returning from endemic countries where COVID-19 occurrence is happening at high rates are at increased risk. And the public health department's disseminated guidance to the medical care community, to our local hospital, to medical clinics, about management of people with potential COVID-19 infection. I wanted to take a minute and talk about the issue of what are called community mitigation activities, closure of schools, closure of large mass gatherings in the community, because there's been some concern in the public about whether or not we should move towards doing that. There are guidelines issued by the California Department of Public Health on these issues that are evidence-based and science-based, and they have criteria that they recommend when and how to issue closures of those other mass events or schools. For example, the guidance for school closures gives 4 different scenarios for recommending school closure. Scenario 1 is what we're under now, where there's no disease activity taking place in your community and there's no community transmission of COVID-19 taking place. There's no recommendation to close schools. There's still recommendations for the schools to engage in good practices to prevent disease transmission in the first place. You would use those for routine influenza anyway. That would be hand washing, covering one's mouth or nose when coughing, issuing hand sanitizers, easily in the school setting, having kids stay home when they're sick until they're better, those kinds of activities. And then the second scenario for recommending school closures is if you start to get a local disease with community transmission. So 2 cases of COVID-19 infection in a community would then kind of step up to the next phase of starting to recommend isolated school closures to prevent transmission in the school setting. A third scenario would be that you have an actual case in a student or a teacher or a staff member of a school, then you start to get more on firm footing when it comes to recommending closure of individual schools. The fourth scenario is if you have cases of multiple kids and potentially multiple schools, then there's recommendations for more widespread closures under those scenarios. So when it comes to school closure, there's good recommendations on when and how to roll something like that out. Let's look at mass gatherings in the public, large meetings, Irish days at Murphy's, local movie theaters, right? People call the health department and they say, Dr. Kelaita, you need to close the movie theater in Angels Camp because people could get COVID-19. Again, we don't have any cases in the community. We have no evidence of community transmission. And just like with schools, the recommendations for closure of public events or mass gathering is contingent upon the demonstration of local disease occurrence happening in the community, and we're not there. So that's why the public health department and I as health officer have not recommended closure of those other, large community events or meetings or mass gatherings in the community yet, because it's based on the absence of demonstrable disease activity in our community. That could change. If disease starts to occur here, those recommendations might be forthcoming. There's still recommendations for people to undertake routine prevention activities that could help keep them well. Events should have hand hygiene capabilities. They should have the ability for hand washing. They should have hand sanitizing stations. People who are sick, they should post signage up and say, if you're sick, don't come to this event, right? People should stay home if they're sick. They should not expose others in a community, especially in a large mass gathering. And there's recommendations now which are new for people who are high risk to elect not to travel on an airplane, elect not to take a cruise, right? Choose not to attend a large mass gathering if they are high risk. If a person's elderly or has underlying health problems, they most likely would elect not to attend an event like that out of concern for their own personal health. So those voluntary exclusions of persons who are high risk are also recommended at this time too. So again, it's a general item about what can communities in our community do to prepare. Again, routine guidance that we have talked about for other respiratory pathogens like influenza for a while now. Stay home if you're sick, cover your cough, wash your hands, don't touch your eyes and mouth, avoid close contact with people who are sick, clean kids' toys, doorknobs, use hand sanitizer, pretty liberally, and call the public health department if you are exposed to a COVID-19 patient or you are at high risk because of your travel history and you develop respiratory symptoms including fever, cough, and shortness of breath. And then high-risk persons should make decisions for travel and attending large community events based on their risk factors. So I want to turn it over to Chris to discuss our emergency preparedness response, and then OES has some comments, and we're going to be available for questions.
Hi, good morning. My name is Christopher Edgerly. I'm your Emergency Preparedness and Response Manager for your Public Health Division, Health and Human Services Agency. I'm going to go over some of the emergency preparedness and response that we are doing here. Currently working, and we have worked with our local, state, and federal agencies during the monitor and to prepare for anything that we have to do with this COVID disease activity that we have. We are continually sending out press releases to the media as this evolves. We are providing ongoing communication with the City of Angels, our local preparedness and response to the COVID-19. We've developed a social media campaign to educate the public. It's all over our website. We've been pushing out press releases and anything that we can to educate the public as to how this is evolving. We've met with our local hospital representatives, both from Adventist, Sonora, and Mark Twain Medical Center, to ensure that they themselves are prepared and they have enough PPE for their staff. The health officer is providing guidance to our medical community on the COVID-19 testing and infection control activities, and we continue to push out that information as well. We meet and have met with our Calaveras Tuolumne Healthcare Coalition. The Healthcare Coalition is not just the hospitals and public health agencies, but it's everybody that provides any type of healthcare or services to healthcare, being Common Ground, any of the transportation agencies, Avalon Healthcare, which is another topic that is getting a lot of steam today on the congregate healthcare for the elderly. We're getting a lot of guidance on that today and have help coordinate with them. We provide case management for suspected cases. So the suspected cases that we have tested so far here, we're providing case management for, and keeping contact with them and making sure that they continue to isolate and quarantine in their homes. We have tested people according to the CDC's guidelines, and Dr. Kelaita mentioned what those were. We've created a COVID-19 specific page on our website that is continuously updated daily with new guidance documents that we receive from both the CDPH and CDC. We distribute a memo and supporting documents to school districts. That was also done yesterday. We keep getting updated guidance on schools, so we keep pushing that out as we get it. We've sent email communication to all the Calaveras County employees encouraging hand washing, and other preventive actions. We distributed printed resources on stopping the spread of respiratory illness to all departments of Calaveras County. We've also sent signage to all of the department buildings to be put up, and it's supposed to be public facing, so they know exactly what they should be doing as far as washing their hands. And if you have any questions, we can probably say that after OES, unless you would like to ask questions now.
Just a real quick question for those that are in fire districts and first responders. Is there any changes to the EMS protocols, or is everything pretty much standard as is?
Standard as is. We've gotten guidance at the beginning just for EMS, but it's now been expanded to all first responders, including law enforcement.
Okay,
So it's pretty much a standard response on PPE for all of them at this point.
Right, that's what I was asking. Thank you.
Going back to the impacts to the medical care system, you brought up that we can only retain so many people, and if we go into a very severe case that we'll be outside the boundaries of what we can actually serve with the hospital in the severe case, is what I'm assuming by looking at these numbers. Is there any plans going forward for retaining other facilities to expand the services if we get to this type of situation? Are we looking at that with like a Cal OES, or like if the schools are out, will we be able to move into a gym and put more people into a facility as such?
There's comprehensive planning that takes all of the things that you just mentioned into account. The hospital and hospital representatives are here. They're free to speak on this if they have any additional comments about beyond what I'm saying. But I've been working with the hospital and the local medical community since I first became health officer here in October of 2000. September 11th of 2001 was the terrorist attacks and the potential for bioterrorism, anthrax, smallpox. That was kind of the beginning of some of our emergency planning for how to handle a surge of infectious patients. We saw the H1N1 influenza outbreak in 2009, and we also had to gear up planning for what we call surge planning and surge capacity for when the need for medical care exceeds what you're normally able to provide. How do you do that? And there are very specific and stepwise plans to ramp up hospital services, medical clinic services to meet that excess demand. Once things get beyond that, the local hospital and medical care community has the ability to expand their services even outside of their normal facilities through setting up tents in the parking lot, through expanding services into non-traditional areas where care isn't normally given to meet that excess demand. And there are even plans to open what's called an alternate care site, which would be a completely freestanding medical care facility in a local high school gymnasium or some other non-traditional care site as well. So even though on that slide I put that there's going to be potentially a need to ramp up medical care services beyond what we're currently ready to provide, we have very specific plans in place of how we would surge the medical care community to meet that excess demand. A lot of that also is contingent upon mutual aid agreements with neighboring jurisdictions, transferring patients to other hospitals, other jurisdictions where they might have care and bed capacity that we could draw upon as well.
Excellent, thank you. That's a question I get quite a bit from the community during these times. Thank you.
Dr. Kelaita, you didn't mention too that you do ongoing tabletop exercises. I've sat in on a few of them that help to understand that coordination and how an incident can expand very rapidly, and how you would be able to take advantage even of FEMA or other options that would be available to you. So I just want to be sure that the public understands that you folks don't just wait for something to happen. These are things that you are planning and you're constantly training on.
Thank you, Supervisor Mills. For the community's information, the public health system and the emergency preparedness programs have been planning for events like this for 20 years.
Any questions? Right. Okay.
Here, I'll just slide in. Brief moment of musical chairs. Good morning, Madam Chair and Supervisors. I am John Osborne, your Director of Emergency Services. We have been in support of the public health officer and their operations since we activated on the 27th of February. We upgraded from normal operations to what's called a level 3 activation. That's a duty officer status, where we are monitoring what's happening at the local level and interfacing with our inland region to get a broader operating picture of what's happening around us and statewide. We began holding daily meetings with public health and to ensure that our response is being facilitated properly and that our public health folks have the resources that they need. In the larger scheme of emergency operations, we as OES have the overarching management task of managing and assisting the emergency services or the emergency support functions, which public health is one of them. So as public health, as the demand for greater operations or less operations take place, we mirror that in our response at OES. So we upgraded to a duty officer status, which mirrored public health, and began holding regular formal conversations with public health and our response partners to make sure that we were getting accurate information from public health and that it was getting out to our field being our first responders, both from the law side and the fire and medical side. In accordance with public health's increased activation to level 2, which is a limited emergency operations center, we stood up the emergency operations center on the 5th. We stood it up and opened it and began holding daily briefings with our field response folks and our state level folks. So we act as the link between the local response and the regional response, which serves as a link to the statewide response, which serves as a link to the nationwide response. So the EOC Center really is the link that gives us all a common operating picture from Chris's operation as the section chief, the operations section chief, all the way up to FEMA. We did that, and in fact, we held our daily call this morning at 8:30, and these calls are meting out questions and best practices for our responders, and we're able to gather the information that they need and either get that information from our public health partners, or our public health partners are able to go out and retrieve that information from their sources, provide it back to us. One of the things that we have been doing is a slight difference in what I would term as normal operations. During medical aids, our first responders are limiting their personnel to an ambulance member and a fire member. They are qualifying the situation to make sure that we don't have a potential for an exposure of a potentially infected person, and then they're resuming operations. The idea behind that is, as you are all very aware, we are a very small community. Our fire departments have very limited and strained resources, and if we were to unfortunately expose an entire engine crew or an entire ambulance crew or both to a COVID-19 patient, that could be crippling for both agencies. And to mitigate that, we are using controlled entrance into the situation that they're on, a routine medical aid, and making sure that we're not exposing an entire engine crew at once. We had a medical aid call that had some potential at the time to have some sickness. It turned out that it was just really a language barrier with the patient, and we used those protocols. We deconned those folks in accordance with the CDC guidelines, and eliminated any risk to our first responders in them being quarantined that way. So I expect that we will continue that until we have a better idea about what's happening in the county. Whoops, I'm sorry. So this is our OAS contact page. You'll see myself and my contacts, our emergency services coordinator, Cameron, as well as our department analyst, Julie, and of course my shameless plug for if you haven't registered for Calaveras Alert, you should think about it. And we are happy as a group to address any questions that you may have.
John, are you using Calaveras Alert for this? I haven't checked it.
We have not pushed out any messaging via Calaveras Alert at this time. Should things progress in what I would say a negative way, where we have a case or we have a need to dispense critical information in a timely manner, we would certainly use that. We have been partnering with public health in pushing out their information and hopefully spreading that information farther out into our community. I have to give a lot of props to public health and the underlying IT team that is keeping their website up to speed. It is being updated literally daily, and really serves as the point of verified information available to our county residents. There's a ton of information out there, or data out there, but what is presented on that website is verified and vetted by these folks sitting to my right and left, and is the best information available to our residents.
Okay, well, I thank you, I don't know, Mr. Italy, if it's you, to put it on the front page of the county website versus having to click through various things. So thank you for doing that. I talk to people frequently, as all of us do. Is there a way we could get some flyers that give, the phone number who to contact or, information on the website for for up-to-date information, and we could just pass them out or hand them out. I mean, I talk to people, and, I don't want to go to the website, or, they want more instantaneous. If there's a way we could get some, I'd appreciate it.
The press releases are on the website. They're in a PDF format where they can be printed.
I
So that's a
understand that,
relatively-
but I had to contact the Director of Health and Human Services because people were saying they weren't seeing them, so I wanted to know where they were. And again, it's as much community outreach as we can. You all are getting those phone calls, and I'm sure the questions you're getting are the same kind that we're getting. And, not everybody reads the press release or looks at the pine tree or my mother lode or whatever. And it's just another way to try and communicate because the anxiety level is quite high.
Yes, ma'am.
I-
And so we can certainly print those and make those available. I'm kind of skipping
It's-
through because I thought I saw I wanted to put back up the phone number.
Okay, I have more questions, but Mr. Stopper does. Go ahead.
Just to finish that point, there is a COVID-19 hotline that these folks have stood up for us. And is it in the presentation? Is there a number there?
Yeah, it says it when you click on the main page. It's right up, the hotline number's right up at the top. I like that, thank you.
You can also call the main line for public health as well, at 745-6460.
Right, I mean, I have more questions, but my colleagues do. Go ahead, Mr. Stopper.
I was just going to back up Ms. Callaway on that. I mean, there are quite a few people out in the public that, watch the news, but they definitely don't click on the site for your press releases, and it's missed. So just a suggestion, possibly circulating it to all the schools and asking them to put it out in their Monday folders or give it to the high schoolers so they all take it home. That's a broad amount of people that if they even put it on their sites and just send it to all the parents home with an email on it and an update, that you would get quite a bit more outreach going through that path also.
And this is, it's really a communicating health information to the public, to other constituencies like the medical providers, the medical care system, the schools, churches. This is a multifaceted production.
Yep.
And so we're trying to meet the needs of outreaching those groups. For example, we did send information home to the schools, for the parents and for the school kids, updating them on what the situation is, information on hygiene and, self-preparedness activities, that kind of thing. But it sounds like we need to do a little bit better job of getting that information much more visibly, at people's fingertips in the community. That's what I'm hearing.
This is Kristen Stranger, Health and Human Services. I did want to let you know that the team right now is working on development of flyers per the suggestion, and they'd been working on them before, specifically targeting vulnerable populations and making sure those get out to the senior centers, additional information. So message delivered, sorry, apologies. Message delivered, and we will continue to push that information out. Just as Dr. Kelaita and they had echoed, we have a multi-pronged communication approach, and so we'll amp this part up.
Supervisor Tuffnell.
I have a couple questions for Dr. Kelaita. Reading the very first part of this where it talked about is a disease or a virus in animals and humans. Animals, can they transmit it to people if they have some strain of it, or?
Coronaviruses are what are called zoonotic illnesses, and that means that they can infect both humans and animals. So the potential for mutation, the potential for the development of novel strains of coronavirus is much higher because it can circulate in other animal species. Influenza is like that as well. Influenza, swine flu, is named that because it has a reservoir of pigs as a host that it can live in and mutate. So the answer to your question is partially that this virus can infect other species besides humans, but you can't catch it from a chicken, or you can't, you can't get COVID-19 infection from another animal species. It has to be from a human to another human. And so I think that's kind of the common sense answer to your question.
Okay, that's a very good answer. The next question I have is, you were talking about community events, and in particular the Irish Days coming up, and because of Calaveras County, we have a lot of people that travel from outside Calaveras County to some of these events. And you were talking about putting aside that if people are sick, don't come. But if I'm infected, but I'm not showing any signs of being infected yet, it hasn't overtaken me, can I spread that even though I don't show signs at the time that I am sick?
Theoretically, yes, but we don't know exactly what the data and what the epidemiology is of this virus. We think that if people are not sick, they're in the phase where they might have contracted the illness, but they're not sick yet, they're not going to be contagious there's a very short window period between the time that a person is exposed. They'll typically show signs and symptoms of illness in about 5 days, 5 to 9 days. And if they don't get sick within 14 days, then they're not going to get sick. But let's say a person was just exposed to the virus a day or two ago, and they're exposed to someone else, but they themselves are not sick yet, the potential for transmission is very low from an asymptomatic person to another person unless they, are showing signs of illness. That's when they are becoming communicable.
Okay. And then one other question I have, and just so I can understand, when we talk about the flu, we have a season, we say the flu season. Is this somewhere similar to that? Is there a season, or is this continue? Can it go into the summer months, the fall, the winter, and so forth? Do we know yet? Do we have any idea?
We don't know.
Yeah.
Some viruses do have a seasonal type of transmission or patterns of infection, like influenza. It would be it'd be very unlikely to get influenza during the summer, for example, because there's more of a seasonal pattern of influenza activity. With COVID-19 infection, because it's not technically an influenza virus, it's a coronavirus, we don't know yet what the epidemiology of this illness is going to look like. We haven't had enough time to be able to determine that yet. So the implications of that question would be that, well, is this just going to go away? Once it gets warmer, once we hit spring and summer, will this all just naturally go away on its own? We don't know the answer to that yet, because some viral illnesses have more year-round activity.
And that makes it a great potential to continue to spread and go. Yeah. Thank you.
And Supervisor Toffenelli, to dovetail on that, when you're in that period where you may have been exposed and you're not sick yet, that is the primary reason that we are recommending wash your hands, because if you unknowingly transmit it and I wash my hands and kill the virus, I've stopped that infection.
Correct.
And that's why that personal hygiene piece is critical at this point.
Thank you.
Dr. Kelaita, you said that the county obtains the sample and transports it to San Joaquin
Yeah,
and to the test lab. So is it that public health is taking the sample, or are our local physicians taking samples?
Local physicians wouldn't be responsible for transporting the specimen. We do have a system in place to transport medical specimens to outside laboratories. If a test isn't able to be done locally, there's a courier system. There are ways of moving samples from one laboratory to a larger laboratory that has testing capacity that we don't have. Such a system exists for the public health laboratory system. Usually, however, the COVID-19 tests are of such high priority and we want the results back as soon as possible. We have physically transported the specimens ourselves. Public health staff have transported the specimens to the appropriate public health laboratory where the testing is taking place.
Okay, but I think part of what I'm asking is who takes the sample? Does public health, or does my personal physician take my sample?
No, your personal physician would consult with the public health department, with myself or my designee, to determine whether the person's an appropriate candidate for testing. If they are deemed an appropriate candidate for testing, then obtaining the test itself is not difficult. The local provider could do that, and then the public health, our department, will facilitate the specimen getting to the appropriate testing lab in one of a couple of different ways.
Okay, got it. If the school's closed, you're the king of the mountain right now, and you're the one that would be recommending that the schools close. Would they be doing it under your leadership on that?
That would realistically happen in one of a variety of ways. The first way would be making recommendations, like, for example, people who are at high risk, can be given health information that recommends that they not attend group gatherings, that they recommend not to go on a cruise ship, right? If a disease activity is occurring to the point where I feel that it wouldn't be prudent for people to get together in mass gatherings, I could issue recommendations to the vendors that hold such activities that those aren't a good idea, right? And I would expect vendors, once hearing the local health department is telling them that it's not a good idea to hold this event, that they would cancel them. The local health officer does have powers to order closure of institutions or large gatherings in the event that there wasn't cooperation with such recommendations.
So I'm going back to the schools and the 4 scenarios that you gave. The criteria is established by CDC?
Well, we get our main information and take our lead from the California Department of Public Health, CDPH.
So if we're in scenario 2, a local disease with the community, and you might isolate, the school might isolate part of their campus, that recommendation would come from you to the schools, correct?
That recommendation would be done very much in consultation with the schools, where we would get together with them. We would explain, scientifically what the situation is, and that together we would partner with them on the appropriate recommendations for closure.
Okay. You gave the information about what's available in the county, i.e. Mark Twain. Does Mark Twain have isolation rooms? Or an ICU room might not be an isolation room?
Well, an isolation room is used in very limited circumstances. If a patient is hospitalized, a patient's sick, they need to be confined to a hospital bed, Mark Twain Medical Center has 2 isolation rooms. One is in their regular medical surgical ward, and the other is one of their ICU beds. ICU bed 1 is a negative pressure isolation room. So this is a room that has environmental, it's designed environmental controls where the air is not recirculated among the wider, hospital. The air is coming out. It doesn't suck, it doesn't blow air out of the room. It sucks air into the room. So that's what makes it a negative pressure isolation room. But, there's only a few of those in the entire community. And the majority of isolation for symptomatic COVID-19 patients would be occurring at home. And those patients wouldn't necessarily need hospitalization unless they were ill enough for that.
Now I'm going to shift the subject a little bit, which sounds very uncaring. But how are we funding this? Is Mark Twain reimbursed, or would they be reimbursed? I mean, because there's a lot of chatter, and I'm not sure how we're managing this.
Well, there are established systems where hospitals and medical clinics and physicians get reimbursed for services they provide. So at this point, because we're not seeing a large influx of patients, the care system is getting reimbursed in the normal ways that they get reimbursed. There's no cost for COVID-19 testing on the few people that we have tested in the community. That testing is absorbed, cost of that testing is absorbed through the public health system. But, in the event of, a large increase in patients and hospital surge planning needs to be activated, reimbursements, become, not a central part of the decision-making process at that point.
I have one more. I'm interested, and I'm not sure if Mr. Ederle, you can tell me, what kinds of calls are we getting on our hotline?
A lot of our calls are originating around the guidance that's being pushed out specifically for their situations, be it the school, community, how do I take care of myself at home, the hand washing issues. We're not getting a whole lot in regards to specifics of healthcare. Most of it is basically our symptoms and concern for family and concern for how they need to take care of themselves.
Okay. Mr. Osborne?
Madam Chair, back to your question regarding the funding. From an OES standpoint, we have not exceeded our county abilities at this time, or our county capacity at this time. Should things become more serious, there are kind of two likely parallel tracks that would take place. Dr. Kelaita, should he deem it necessary, would declare a local public health emergency. And in turn, we would declare a local emergency. And then we would, much like PSPS or a wildfire, we would bring something before you guys, and then we would make a formal request to the state for California Disaster Assistance Act funding and or FEMA funding. And so those two tracks would slightly diverge if we, from a public health standpoint, they were within their capacity, but as a county from the OES standpoint, overall standpoint, we exceeded our capacity. There's a small likelihood that I would declare that as a disaster once we exceeded our abilities to have an avenue to seek those CDAA or FEMA funds.
Thank you. Just any other questions at the moment from my colleagues? I open it up for public comment. And if there are questions from the public, we'll just write the questions and answer them at the end.
I understand.
Mr.
Thank you.
Segala.
Al Segala, Taxpayer Association. I'd like to mention this would be an excellent program for our Taxpayer Alert. We interview people that have knowledge of significant things in the community, half-hour show, and the next one is, we'll be taping on the 26th of this month. So if one of you is particularly good speaker, you're invited. There's some things that I looked at that are not generally talked about in the media. There seems to be some nutritional aspects to how our bodies are able to fight off influenza and other diseases. There's a study now in China, 3-month study, it's already started, to test high dosage IV vitamin C. And there's a number of cases, as I read the doctor reports, of quite a bit of success of high dosage vitamin C for fighting viruses, and also septic and other things that apparently when God designed us, He left out the ability for us to make our own vitamin C. He did a better job on dogs. Dogs can do that, and they automatically produce their own vitamin C, and they're able to have a better task in fighting viruses. There is 2 things that I know of that's in the drugstore over the counter. One is Airborne and the other one is Zicam. These are basically vitamin C, and I know that Airborne works because at any time I have just a hint of coming down with a cold, I take that and it's gone in a day, and which is what they claim in the plenty of studies that show that it does work. What's curious to me is why isn't this information widely known? Why aren't all the doctors who are going to be exposed to viruses making sure that their blood level of vitamin C is high enough to provide immunity? So I would like to see more studies on this by our local doctors and sharing that with the results of those studies with the public. Thank you.
Thank you, Mr. Segala.
Dr. Prapana Randall Smith, doctorates in educational leadership, not medicine. Great presentation, and I commend you for all the efforts that you're taking. And I thought that the questions from the board were excellent. Although I hate to say that I think that our preparations are woefully inadequate, and here's why. According to the CDC, last year, our flu season that ran its course affected 42.9 million people. Of those, 61,200 were killed by the flu. 61,200 divided by 42.9 million is 0.0009%. According to our latest data from the worldwide cases, which could be questionable because we don't know how much we can trust out of China and a few other countries, of the closed cases, that is cases that ran their course, there's as of 10 o'clock this morning, 68,855. Of those, 4,095 perished. That's 6%. That's 6%. That is a massive number. If you look at currently infected cases, it's 12% of the 48,000 are in the hospital or they're serious or critical. Now, if we were to see this thing spread the way the flu spread last year, assuming the fatality rate is 3%, we're looking at almost 1.3 million people in the United States perishing. If the 6% holds, we're looking at about just under 2.6 million. This is serious, and the reason I bring this up is not to get everybody scared or to create a panic, but I would like to ask this board and every other county board in the country, every city council in the country, every legislature, to call upon the federal government to allocate significant resources. We spend hundreds of billions of dollars on national defense. This is a national security issue. We need to call on the feds to bring in the resources to build those centers, to bring in the doctors, to prepare for this thing. Because if it's as bad as it looks, we're going to need a massive response to it. And I think you're all doing a great job. I like what I hear about putting together possible centers, wherever you put them, whether they're in school gymnasiums or wherever, but we're going to need them. And Calaveras is not an island. It hasn't come here yet, but it's going to. Thanks. So,
Thank you.
Yep.
Thank you, Dr. Smith.
I'm Will Moore from San Andreas, and your slide here says that this disease is spread mainly by droplets. And I see China and Italy and so forth, people wearing face masks. And then I see expert opinions saying that, well, that's nonsense. Those face masks don't do any good to protect you from somebody else's disease. It's good to not spread it. And here, all the emphasis is on hand washing. Well, if this thing is spread by droplets from somebody's lungs and so forth, what's all the emphasis on hand washing and not on wearing masks?
Thank you, Mr. Moore. Any other public comments or questions on this item? I'm going to close public comment and bring it back. Could you just answer the question about the face masks and the spreading of droplets?
There's several mechanisms by which an illness can be transmitted from one infected person to a non-infected person. When it comes to respiratory viruses like COVID-19, the primary means is through droplet transmission. That's when a person coughs or sneezes. The virus can be suspended in a water droplet, and it can be passed a small distance. That's why close contact is defined as 6 feet or less. And then that can be inhaled by a person who breathes that in. A surgical, and there's different types of personal protective equipment that people can wear. A surgical mask is probably one of the lower forms of personal protective equipment. It's just a cloth mask that goes over the nose and mouth. And if a person coughs into that, that's enough, we think, to suspend the droplets that the virus is contained in and prevent that from being able to be transmitted from one person to another. Healthcare workers are recommended to have a little bit higher level of protection if they are dealing with a potential COVID-19 patient. That's called airborne precautions. Airborne precautions would be the healthcare provider doesn't wear just a regular surgical mask, but rather they wear something that's called an N95 respirator. That has a much finer level of filtration and can get rid of smaller particles than just a regular surgical mask. Also to wear a face shield, gloves, and a gown. So that level of protection we recommend for healthcare workers is called airborne precautions, and it's for people who are tending to a potentially contagious COVID-19 patient. So a regular surgical mask would be good for the majority of patients and the majority of situations of transmission in the community. And that's what we would recommend. If a person comes into an emergency room and they're coughing, there'll be a sign on the door that says, put on a surgical mask before you even sit down in this waiting room. And that provides, with this particular type of illness, a level of protection which we feel is adequate at this point.
Thank you. The comment or question from Mr. Segala about how he thinks airborne and Zicam are wonderful, and why don't doctors, I guess, promote this? You don't have to comment on it by brand, but is there any comments you want to make on that?
When it comes to recommendations for things that people can do to treat themselves, most physicians would want to see that there's scientific evidence behind that recommendation. When it comes to remedies like Zicam or vitamin C or zinc or other types of interventions, there haven't been scientific studies that have been performed that demonstrate the effectiveness of those interventions beyond just sort of hearsay and anecdotal experience. So for that reason, I wouldn't be on a solid footing to recommend those to the general public. When it comes to certain things like, say, taking glucosamine or chondroitin sulfate for knee pain, right? I have patients that do that and they report to me that, doc, that helps my knee. I'm not going to argue with that person, right? I'm not going to tell them, no, it doesn't. It's not helping you. There's no evidence that that helps you. That's fine if that individual feels that remedy helps them. They're perfectly welcome to do that. But I'm not in a position to recommend that to the wider public or patient population without more scientific evidence that shows that that's effective.
Okay, thank you. The other comment was Dr. Smith saying we're unprepared for a major disaster and to call on the feds. And I know there's cooperation now and there's lots of talk. Mr. Osborne, did you want to address that in any way?
Thank you, Madam Chair. Again, that tract follows the local emergency. All disasters or incidences are local. That's where they start, and they start with us. And once we are affected to a point that we can no longer, within our bandwidth, if you will, handle that local emergency, we would first reach out to the inland region of California, and then California, and from California to the federal government. I am aware that the federal government is providing some funding. I believe it's being funneled through CDC at this point. So the federal government is supporting our local operations through several ways, not only monetarily, we don't know necessarily us specifically yet, but through that money stream with CDC, as well as providing us with resources to help us make sure it stays local.
Okay, thank you. Do my colleagues have any other questions? I'd like to thank Mark Twain for being here. We appreciate it. Is there anything that you would like to say? You don't feel obliged, unless you have some stress balls you want to hand out? No?
As long as you wash your hands first.
Oh, yeah. Thank you. We appreciate your being partners in this. If there's no other questions or comments, we will close this topic and we will take a 5-minute recess. Thank you.